Yes, sir. Good morning, everyone. It's 8 o'clock. I think we will go ahead and get started. Dr. Lambiase needs no introduction to speak to our Department of Medicine, but I'm going to do one anyways. He is our program director for the GI Fellowship and professor and chairman of the Department of Medicine here. He is a graduate of University of Miami School of Medicine and completed his residency at University of Pittsburgh Presbyterian Fellowship Training of the University of Florida College of Medicine in Gainesville. Each year during my annual faculty evaluation, he asks me, if I fired you, what would be missing? And so one of the things here will be an interesting answer to that question in terms of how does that apply in artificial intelligence in gastroenterology. So with no further ado, Dr. Lambiase.
Oh, thank you, Mike. Yeah, it's a hypothetical, of course. You know, we don't like firing people, actually, but I actually do think it's interesting to evaluate your progress in your life and in job by thinking, well, what am I? If I didn't do this, what would I be doing? How could I be better, and that sort of thing. And so it's actually interesting. It does sort of tie into this subject. This is I'm going to speak today about a subject which I know very little, and so I'm going to ask your forgiveness on that. But I think that there are really two areas in medicine that I think that are coming down the pike like freight trains, actually. One is this artificial intelligence stuff, and the other is, you know, genomic or precision medicine. And I think that those of us who are in the trenches every day and are practicing medicine, we should at least learn how to think about this, at least become somewhat cognizant of what people are doing. And, you know, frankly, one of our jobs is to help for our patients is to help sort out the blizzard of information that comes out and is available to us, and to be able to edit that, right? I mean, everybody can Google stuff, right? But the real skill, what we do, is to be able to filter out some of the noise. And so what I realized is when I read most of these artificial intelligence papers, they define a problem. It's good, I understand that. And then they basically have an outcome, and I understand what they're saying, but it's that middle part about, usually it's like, and then a miracle occurs. And then, you know, so just trying to understand what happens in the black box, and at least on a cursory level, and we'll talk about that. So these are my disclosures. I never thought that having a small equity position in Microsoft would be a potential conflict of interest, but in an AI talk, I think it is. I'm a bondholder in HCA, so if any of you are going to go to Park Ridge, go get back to work. And we've had grant support from Magnetic Eye and AbbVie. Other disclosures, some of the journals favor more broad disclosures on the part of speakers. So here it comes. I'm not a computer or IT expert. Does anybody have an IT degree or computer expertise in the? Good. Then I'll lean on you. You can call BS on stuff, and I might do this. I gave the talk at Tulane as a visiting professor, and there was actually a software engineer in the audience, and he was actually extremely helpful because he could when I stumbled, he could help explain things. By nature, I'm skeptical of new techniques and technology, and so that'll probably color some of my comments. And this was from New Orleans consumption. I'd ridden in 6 Mardi Gras parades, so that's a disclosure too. So today we're going to talk about what is artificial intelligence and what is machine learning, and specifically look at some examples in gastroenterology and talk a little bit about what we're doing here in Chattanooga in terms of our protocol and the grant that we have looking at artificial intelligence and polyp detection. What's the current status, and then what are some future directions? So let's get started. So what is artificial intelligence? And it's been in the news a lot, right? I mean, you have that one commercial, it can help you brew a more favorable beer. You know, you have the person that says it can shorten the time to get a new beer on the market for 24 hours or into 24 hours. There's all of this talk about self-driving cars, and that's also an example of artificial intelligence. Big companies now are using them to review job applications. So before your job application ever sees a human, if you're in corporate America, it gets reviewed by artificial intelligence. There was a commercial saying that it can be used to optimize race car performance, looking at all the variables and how do you tweak your spanner, for example, that can do it. And then, of course, the best example is it automatically keeps a plane from stalling by pushing the nose down, which is a 737 MAX. And so just some examples of how AI could make your life better, and perhaps there might be some problems with it as well. So what is artificial intelligence, right? It's simply put, it's machine intelligence that mimics human function. So it's basically where the machine looks like it learns without programming from humans. So this is a very old concept, started back in the 1950s, and the sort of the simplest thing is that if you think medicine's bad for acronyms, you should see this IT world. But there's one called GOFAI or GOFAI. It's good old-fashioned AI, and that's the if-then or rule-based type stuff. So if you try and prescribe erythromycin and warfarin and Epic, you get a big error message. Also, if you try to prescribe nuts or seeds to somebody who's taking something completely irrelevant, you get Epic warning. But basically, if something happens, then that triggers a response, and that's the earliest example of artificial intelligence. And you can see it. We have a computer program in the endoscopy unit that generates our reports. And so if Dr. Murphy, who's a GI fellow, clicks that he put a clip on an ulcer, it'll come back up and say, well, because he clicked on that, it's 43255, which is EGD with control of bleeding. And so that's pretty simple. And it's good as far as it goes, but it has a lot of problems, just like the Epic prescription warnings and that sort of thing. So going one step further, what is machine learning? Machine learning are algorithms built from given data that predicts or makes decisions without explicit instructions. And this is really where you start getting into the machine learning. And there are different ways of learning. You can actually supervise learning. So a human goes and sets the parameters and says, this is what we want and this is what we don't want, and figure out a model. And so the simplest way for this is, if any of you have ever done regression analysis and research, this is sort of the same thing, where you set a regression equation and look for relationships in data to help you predict. And I think we do this all the time. But computers can actually, because of their vast computing power, can actually look and cluster characteristics together on their own. So you can basically tell the computers, look, pull everything that's like together. And the computer can actually look at data sets and images and start pulling things together that we never thought of. And that's unsupervised learning. And that's actually one of the things that you can do with feature learning, which is where the machine looks down and looks at the different features from raw data. So, does a polyp, is it curved? You know, how do you determine whether something is it some way the vessels look? And it's things we may never have even thought of. And there are a lot of examples of this. For example, there was a study on pancreas cancer that they looked at, and they found that one of the anti-hypertensive drugs in all of was associated with a better outcome. And it was basically because they were looking at all of the electronic health records, and the computer pulled it out. No human told them to pull that out. And then, of course, now people are looking to validate that with mechanistic studies. And so what happens is in this, they learn the features first, and then they try and infer the functions between the inputs and outputs. In other words, what is the relationship? Then it gets even more complicated. It's called deep learning. So what the computer does is it goes through several layers of pooling these results and analyzes each layer of the results to get a further and more refined. So it learns, and then it learns again, and then it learns again. And because of the way that takes a lot of computing power, they do something called a convoluted neural network. And basically what it does is you give the computer instructions on how to pool things together so that it tries to not look at irrelevant results, but look at only relevant results, and so that it makes it easier and more efficient to compute. And so these are the, when you read an AI paper, most of them nowadays are in this deep learning or convoluted neural networks, because that's the sort of the state of the art. And it gets all of that math stuff that I tried to avoid in college. Is sort of where this goes here: Bayesian analysis, vector algebra, these kind of things, and it gets real very, very quickly. So I think it would be hard for a physician to follow this unless they had a very deep math background. But the key thing is that most of the better papers now are looking at convoluted neural networks, where the computer, where there are ways to look at the data and analyze it that sort of try to focus on relevant data and don't focus on irrelevant data. But as you can imagine, every time every step in the way involves assumptions, and those can lead to errors, and that's the other thing that you have to wonder as well. So here's sort of a schema from World Journal of Gastroenterology, and I guess it's blurry, and I apologize for that, but that's it just didn't come off well when I stole it. But here's on the top, basically artificial intelligence is any technique making a computer or software mimic a human function, such as learning or problem solving. Then a subset of that is machine learning, which is a technique of artificial intelligence for automatic learning and improving without being explicitly programmed. And then there's deep learning, where there are multiple layers of this, and so that's sort of how this works. And just to show you what happens, so classical machine learning, where they look at different polyps or cancer here, and what they do is the machine looks at, tries to find different features and classify, well, that's a benign, that's malignant. So it tries to come up with a function between the two. What happens is that they do multiple layers. So this is irregular, this is regular, and then and then regular ones may have a different color, and so there are different levels of learning, and you get a more refined output. So this is sort of the difference between classic machine learning and deep learning. And then to sort of complicate things further, there are different ways to look at this. There's sort of the supervised training. So what happens is that you get a data set where you know the outcomes. So some are malignant, some are not malignant, and what you do is you identify those for the computer. So you say these are all malignant, these are not malignant, and what the computer does is there's a training where it looks to tell the difference, and it does this regression, and it predicts it. So that's the most simple. And then there's this unsupervised learning where you just say, hey, tell the difference between these guys, and it looks at different clusters and different patterns, and it finds the different distinguishing marks, and then go back and look and say, well, these cluster together, and so this would help you tell whether something's malignant or not. And then the last thing that sometimes we do is we run this supervised training, and then we go ahead and we get more data, and we look again and we say, well, you made some more mistakes, and so you refine your model. So right, you get an input, there's training, you get the output, and then you say, well, we should tweak this. Let's look at some more stuff, and then this is called reinforcement. And so this is really the cycle where people do, and I'll elaborate on that in a minute. So let's get a concrete example, because it's hard to understand this in the abstract, I think. So suppose you were applying to medical school, right? And there were two variables that people thought were predictive of your performance, right? And so we know people who did well. Let's call high performers, or people who do well in medical school, let's give them a 1. And let's give the people who turned out not to do so well, let's give them a 0, okay? And so what we can do is we can plot. We know that test performance, let's say their MCAT performance and their college GPA, sort of are predictive and cluster together. So if we plot out test performance on this axis and college GPA on this axis, we can see that there's a cluster of the high performers in this area, right? And so what we can do is we can actually set a hypothesis in the computer that says for all of the people that score above a certain test who have a certain GPA, those are the people that we want to look at, and those are the people that we want to interview. So that's basically us setting our model, and then so you can do this pretty easily with almost any machine, and it's sort of akin almost to regression that we do in research. What becomes interesting is where you set the machine, right? Where you set the hypothesis, right? So you can choose to set the hypothesis as tightly as possible, right? And only include the area in the graph that includes the ones. Or you can do it as loosely as possible and go out and do to where you would not miss anybody, but you wouldn't include any of the zeros, right? And so that's sort of where the wiggle in terms of the fit of the hypothesis comes in. So if you had this hypothesis that for high potential and you just fit it to the data, that would be there. If you did it and caught all of the high potential, so you had the actual high potential, it would be out here. And then this gray area is that there are false negatives if you had too strict a potential. And so what this is called is if you do it here and you do too strict, that's an error called overfit. And so overfit is an error where you're too strict on your hypothesis, and you only catch people and you miss some people that would otherwise be high in the real world. And then there are some other errors we can talk about. Now in the real world, you don't get squares very often, although you try to make it as simple as possible. And so this is sort of a more actual real world where the shape is more irregular, and that's where the computer comes in, can help you define. But you can see a lot of the AI data talks about where this fit comes in, how tightly how you adhere to your data set, and how well it predicts. Sort of like sensitivity and specificity in research, in clinical research, and trying to look at our ROC curve and trying to see you optimize sensitivity and specificity. You try to get the best model, and so this is really, I think, critical to our understanding of AI papers. When you look at an artificial intelligence paper, I don't know whether we're always going to be able to understand the computer architecture or the learning or stuff. But the real question that you have to ask yourself is how well does their model fit not only their data, but how applicable it is to the future. It's like any other research thing that we look at. So basically, with machine learning, you try to find a hypothesis that keeps the error to a minimum, right? How much you don't detect either people who are high potential or whether you include people who are lower potential in our example. So the reason that you would do that is because data is noisy, right? So noise is unwanted anomalies in data that disguise or weaken underlying relationships in the data and hamper learning. So why can you get noise? Suppose you're studying something. Pick something. You're studying asthma. You're studying anything, response to a drug. You're studying pancreatitis. Why would you get noise in the data? Well, if you think about it, missing data would be a big cause of noise. So somebody misses a data point. Somebody misclassifies a data point. You don't have the GPA of one of the pools of applicants, or and you do thousands of them or something. That would make it harder to classify. The other thing is misclassification. If somebody makes an error, right? If somebody's GPA, somebody carries a decimal point or something, and you say, well, how can that happen? But how many of you work with? We work with Epic. How accurate is the data in Epic? Is it 100% accurate? Right. So if somebody does an EHR analysis, right, and they're doing artificial intelligence, and all of a sudden they're looking at med lists. Let's say, let's pick something you see in clinic, and they're trying to look at your med lists, and they say, well, everybody who's taking losartan has diarrhea or something, and they're trying to look at the relationship. Well, in my experience, very often people are not always on the medicines that they're taking or whatever. And so this is a problem with noise. And then there's also a problem with hidden and unknown relationships in the data, right? So let's take a GPA test score from the news, right? There were certain people who were clients of for college admissions, who were certain clients of a guy out in California, right? Who they were able to get some help with their SAT scores, or they were able to get and so their correlation between their GPA and their SAT scores there was a hidden relationship, and that relationship was their mom and dad paying somebody off to take the test for them, right? You didn't know that, but if you built a classification with just GPA and SAT scores for college admission, and you didn't know all of the relationships between them, you could make a false outcome. So that's another series of noise. And so when you analyze data, it's just like any other clinical study that you want to look at. You want to look at how good is the data sets that they're using, how reliable is the data set. Are they using discharge data for something? Are they using endoscopy images that are blurry? What platform did they use? So this is something that you should look at when you decide whether a paper is a good paper or it's something that should be put aside. And also, did the authors think about possible unknown relationships, or did they think about all of the possible known relationships? Obviously, you can't think about unknown relationships, but you can think really hard. And did they at least account for any confounders, right? So then the other thing that you have to worry about is with the performance of the hypothesis on new data, how generalizable is your hypothesis on the new data? So when we look at the GPA versus the MCAT scores, do we really do a good job? Do we really predict going on due data? So if you overfit, if you underfit, it's too simple a model, and there are more errors. There's also a possibility that you're too tight and you miss people. And then there's a big problem where they look at a training, they call it a spectrum bias. And this is like some of the biases that creep into clinical research, where you pick a set of people that don't correspond to the general population that you're going to study. So basically, if you did MCAT scores versus GPA, and you only did it, and you used your testing set were only graduates of small New England liberal arts colleges, for example, you may not be able to extrapolate that data to people who went to land grant colleges, or who went to or who were SEC graduates who were busy on Saturday afternoon or something like that. So these are things that I think that need to be thought about when you evaluate a paper that has AI. So am I doing okay? You got we're okay? Anything to add with your computer background? No? Nothing? Okay. So how do you know that the AI study is doing a good job? And I think there are a couple of things that you have to think about. The first one is what happens is that they do a training set where there's a bunch of data where the computer looks at it and generates the hypothesis. Then there's a validation set where you know the answer, but you test your hypothesis on it. And then there's another set where you look at the performance in a general population, and then you try and evaluate that. So the first thing is what's the amount of data in the training set? You need a lot of data. It's not sufficient to use 50 or 100. They have to use hundreds of data points. You also have to look at the successive generalization, both in the validation set and the testing set. And then the simpler the hypothesis as a general rule, the better it is. So if they have this very crazy multiple variable hypothesis and equation, those are less likely to be valid than they are that are simple. So simpler is usually more likely to be generalizable. So we talked about the outcomes just a second ago. So there's a training set, a validation set, and a testing set. And to be a good paper, they really ought to report all three of these. They really ought to report all three of these. It's like when you do now anymore for genome-wide association testing studies, that they're by agreement of all of the journals now, GWASs have to have a validation cohort in them. So you have to be able to, it has to be replicated, otherwise they won't be published. It's not the same in AI, but it probably should be. There should be a validation cohort before they're published, right? So you go ahead, you show the, and I'll show you this in a second, but you show the computer 50 polyps and 50 not polyps. You have it make an algorithm. Then you go ahead and you show it on a known data set and see how well it predicts. And then you go out in the real world and you do testing, and you see how well it does against some other gold standard. You can get two results with machine learning, right? You can get a discrete, right? And that's what we saw in our example about MCATs and GPA, 1 or 0, yes or no. But the other thing that they can give is that they can give a probabilistic. So you can say that they have a 70% chance of being a 1 or a 50% chance. And what that does is that allows human intervention to set a cutoff. Now, of course, as soon as the humans set a cutoff and say we're not going to take anybody who doesn't score a 240 on step 1, that becomes a 1 or a 0. But what it does is this: you can when you run a machine learning process, you can actually set it as a probability, and then humans can come in and decide where the cutoff is as well. So again, we talked about. And then the other thing is what about the data sets? And again, it's just like clinical research. You need a large volume of data. You need it to be variable. Homogeneous data, it tends to create errors because it doesn't account for variability in the real world. Some sort of completeness. So in other words, the less selected the sets are, the better that they are. Right? The more that they look at an example of the whole world of what's being studied, the better you are in terms of your outcomes. And then again, sometimes just because of computing power and economics and that sort of thing, human insight is appropriate. So sometimes you'll see where they'll say we didn't include these particular ones, or I'll show you a study where they characterized different functions of polyps, different types of polyps, and they used human insight to make the discernments. And these are the ways that data is handled with machine learning papers. So that's sort of a brief overview of things that you look for in AI papers and things that you look. It's essentially like looking at clinical research, but with just a different sense of tools. And just things to help evaluate the paper. So we're going to look at where AI has been used. Just a couple of examples in gastroenterology, and where it's been used recently is in image recognition. And Dr. Beard's back there, and Dr. Kalun have been doing working with a company looking at image recognition for polyp detection. And I'll show you a little bit of data on that, and maybe ask for an update. It's been used for tedious or time-consuming tasks. One of the things that I find least pleasant about being a gastroenterologist is looking at a capsule endoscopy, and just because you look at thousands of frames and you have to sit without blinking for about 40 minutes, which is painful for me. And so having the ability to screen those things and look for what you're looking for, it's been helpful. Diagnosis, so have you been able to look at symptoms and predict diagnosis? And then prediction of prognosis is something that's made a lot. And actually, one of the things that's interesting now is it's not in gastroenterology, but I just saw a paper where pre-transplant screening of donor kidneys is now, they have an artificial intelligence tool where they can look for numbers of viable nephrons and screen all of the histology, and be able to flag areas of interest for the pathologist. So if they get up in the middle of the night, for example, the computer helps them make the diagnosis. And these are examples of where these things are going to come into play, and where they've already been papers in gastroenterology. So there have been areas of things where there have been a bunch of really small reports in pancreatitis, ulcerative colitis, where they've been hampered by small data sets for prediction of prognosis, but now there are some studies that have had bigger data sets. And so one of them was published actually in 2011 in GI bleeding, where they looked at an advanced neural network, deep learning, which was trained on a data set that had a 50% mortality in upper GI bleed. So actually, if you think about it, it's very severe upper GI bleed. It ran about 2,300 patients versus their Rockall score, and I'll show you what a Rockall score is, and it evaluated the accuracy in predicting mortality. And there have been subsequent works. Last year at the Digestive Disease Week, they presented an update on this where they looked at a testing set, and actually this group showed that there was some pretty good validity. So how many of you know a Rockall score? We don't use it very much because it's I'm not a big scoring and it doesn't pursue well. But basically, what it says is that if you have your age, whether you're in shock, whether there are comorbidities, whether there's signs of bleeding, and the diagnosis, all contribute to your outcome. And so if you have a higher score will get you a higher mortality, right? So if your score is 0, so if your age is less than 60, you're not in shock, you have no comorbidities, there were no endoscopic high-risk stigmata, and the diagnosis on endoscopy was either a Mallory-Weiss tear or no pathology, your mortality is very, very low. Whereas if you have like liver failure, a malignancy, you're in shock, and you're over 80, you're pretty well screwed. And so this is a very rough way to try and characterize it. So what they did was they were able to look at various and sundry clinical factors. So what they did is they looked at all of their electronic records. They looked at their meds. They looked at all of the clinical factors that they could load in. And what they did is they came up with an algorithm where they were able to predict, both on a testing and a validation set, with about a 97% accuracy, who was going to die and who wasn't with upper GI bleed. Sensitivity for mortality was about 84%, and the specificity was about 98%. Positive predictive value was about 64% versus about 7% on the Rockall score, and the negative predictive value was also high as well. And the likelihood ratio of a positive test was about 33 or 34 times those who had a negative test for dying. So, and then that, like I said, the data was very similar. So this was the first where they looked at a testing set and a validation set, and this is what they came up with. They subsequently published. I don't know if they published it in a journal form, but they gave their data just this year in a large validation set, and it came out sort of the same. This is actually a hard study to do because how often do people die with upper GI bleed? It's not very common, so it's a hard thing to do. But I think that there will probably come a time when you'll see an add-on to your electronic record where you're going to have to click through a warning where it says this patient's at high risk for bleeding. And you say, well, I already know that. Well, you'd be surprised, for us at least, when we get called where people, the first people to see the patients in the medical center don't actually, they have a hard time telling who's sick and who's not sick. And so this would be a good way. And sometimes we get confused, too. George, have you seen anything with this being elaborated on or anything recently? Yeah, there's all kinds of stuff where people are looking at it, but I thought that this was interesting because I think if you know somebody's sick, maybe you go down and get the blood bank to put a wiggle on it, and give them some blood, or get them to an ICU, or put a bigger bar IV, or drag Dr. Murphy out of bed at 2 in the morning or something like that. Whereas if they look like they're not sick, maybe you let Dr. Murphy get a few extra hours of sleep, and so that might be helpful. So we do the other areas. We do capsule endoscopy. Capsule endoscopy is a technology, right? So we can scope pretty much. Standard scopes pretty much get down to the jejunum. If you push real hard, you can get almost to the ligament of Treitz down in this area. And then the colonoscopy can go maybe 10 centimeters up into the terminal ileum. So there's a large amount of small bowel that's not seen. And so this crazy professor named Paul Swain from London and collaborated with ex-Mossad agents who had very small cameras and developed this capsule endoscopy. And basically what it is I know you've all seen this, but it's a capsule. It flashes. It takes 2 pictures a second, and it radios it out to a box that's about the size of the old, the first generation iPods, or maybe an old Sony Walkman, if some of you are old enough to know what that is. And then basically what we do is the capsule passes the way everything does. We don't want it back. We don't get it back. A couple of patients have tried to give it back. We don't want it. And then we take the hard drive and we take the study and we download it to a hard drive and we watch it like a movie. And like I said, it compresses 8 hours into about 40 minutes, but it's extremely tedious. If you blink, if you turn your head, if somebody talks to you, if they say, hey, you got a minute, you could turn your head, you can miss something. So it can be kind of a very difficult thing to do. So this is an area where artificial intelligence, where things can look at the images, would be very helpful. So here was a study that was just published in GI endoscopy, where they looked at about their training set had about 4,000 capsule endoscopy videos, and they broke them into normal images and images with vascular lesions. And then what they did was they took 600. They took the best 600 normal images. So this is Human Insight, right? Human Insight. These are the best normal images. So of course, then you have to ask yourself, did they really do a good job? Is there something, And then they took 600 images with typical angioectasias, is what we were looking for, which is little bleeding blood vessels. And again, did they do a right job? Did they include everybody? Were they really typical? They took 300 and 300, and they made those their the training set, and then they did 300 and 300, and that's their validation set. They haven't done a testing set where they've taken it out. So that part of this paper is not there. We don't know if it's been validated in the real world, this algorithm. What they did was they looked at they put together, with using deep convoluted neural network and deep learning, they put together, there was an algorithm where they were able to look at, to try and tell the difference. The computer could tell the difference between angioectasias or normal images. And what they found was that using their algorithm, they had a negative predictive value of about 100%, a positive predictive value of 96, and a sensitivity of 100, and a specificity of 96. So they did, and it took 39 minutes of processing time on the optical processor to look at that. So, this is about the same amount of time that I would look at a study, but if their results are probably as good as mine are, they haven't compared it to humans yet. But this shows that at least in their training and their validation set, that they can get very high accuracy. Now the next step is to go out and do it in the real world and see whether it's hopeful. And then the question is the problem is it was an optical processor. Right now we run these on general desktops that we have, from Anthelio, and I suspect that this took a very high-speed processor to do. And so the real question is can you get that kind of computing power? And I'm sure for a $4,500 or $10,000 upgrade you probably could, but that's one of the issues. But this is another area where it can be helpful. Another area where it is a potential. So we do a lot of colonoscopies. I mean, everybody gets a colonoscopy in the United States when they're over 50 years old, and if you have a small colon, if you have small polyps, trying to tell what a small polyp is, and if you're able to resect it and throw it away rather than to look to see if it's a high risk. So if it's a hyperplastic polyp, it really has no neoplastic risk. If it's an adenoma, it has a higher risk, and you kind of want to know. And if you're able to either diagnose and disregard non-neoplastic polyps, or you take small adenomas and you're able to resect them and throw them away and not send them to the pathologist, it has a potential for huge savings in the healthcare system, right? If I don't biopsy a polyp, then it cuts the cost of the procedure down, and it also cuts the cost of any pathology that's done, analysis is done. But on the other hand, I run the risk of not being able to, of making a mistake and missing a high-risk lesion. Because what we do is if somebody has if somebody has an adenoma, we follow them more closely than if they don't have an adenoma, right? So if you have no polyps or only hyperplastic polyps, as a general rule, you come back in 10 years. If you have an adenoma, in general, you come back in 5 years. So that's the general rule. But this has a potential because of so many colonoscopies being done. If you could refine how you do this, it sounds like a trivial issue. And for each patient, it probably is a trivial issue. But if you look at the whole system, there's a chance for a lot of savings, and it's money that could be spent on other things, for example, anything else, really. So here is a paper that came out of Japan. Type A polyp, what they did is there's a, and I won't get too into the weeds on that. There's a technology called narrowband imaging where the endoscope, and this is a common now on all of the endoscopes, where the endoscope is able to manipulate the wavelength of light that's interpreted by the computer. And what it does is it makes blood and blood vessels stand out. And we're also able to magnify as well. And so what they did is they used magnified narrowband imaging images of polyps to classify them, and basically they classified them into two categories. There are all these different, there's type A, B, and C polyps, and then C is C1 through C3. It's not really important. Type A polyps are non-neoplastic, clearly non-neoplastic, validated by pathology in this group, and type B and C3 have features of neoplasm. And for the gastroenterologists in the group, these are the ones with the capillary loops and other features of neoplastic polyps. So what they did was they took two training sets that were very well validated. They spent a lot of time looking at whether the images were good images versus bad images, blurry, whether they were like images that I took that you couldn't tell what the hell they were, or they were actually really well done images the way Kessler would do them, and then they validated a lot of them with pathology as well. And so they were able to put this training set together. And what they did was they put them through a advanced neural network where they looked at key points were extracted. They looked at lower features. They were able to put an algorithm together that clustered non-neoplastic versus neoplastic characteristics, and they were able to have a classification result. And they were able to put an algorithm together that separated these two groups together. And then they actually ran a validation set as well, where they knew the answer, but they gave the computer sort of an undifferentiated to see how it worked. So it was actually fairly well done. Again, the testing set was not reported in this trial. So, and then of course they asked the endoscopist, "What do you think? Is it neoplastic or not? Right? Is this a neoplastic polyp or not?" And what they found was that the algorithm right now does about the same as the endoscopist. That there's probably not, at least in their world, was not a benefit necessarily over an experienced endoscopist. Although these were all very, very experienced endoscopists in this technology, and so there's a bias. So this I would say is biased. There's an expert bias here, and this may not be what we would get in the real world in this country doing endoscopy. But the algorithm is good. One of the things that's interesting and that they didn't look at is whether they were additive. In other words, did the endoscopy pick up things that the algorithm missed, or did the algorithm pick up things that the endoscopist missed? And we didn't report that. But having a backstop to the endoscopist is helpful. And there are all of these different. This fits into a body of literature in GI now where they talk about having an experienced nurse also watch the endoscopy. That helps with adenoma detections. And so maybe this is another pair of eyes. But I think this is an area where it's looking. And this is just the first iteration. So obviously the problem is that the very, very experienced Japanese endoscopists do very well. So it's hard to improve upon them. But if you can get this is sort of baked into the machine, then it becomes in case they're having a bad day, it becomes another sort of backstop. And it also gives people some comfort that if the machine sees it and you see it, maybe it's okay to make a clinical decision on that. So last is some of the work that Dr. Beard and Dr. Colloon and others are doing here in the group, which is looking at screening colonoscopy. So screening colonoscopy and screening for colon cancer in general decreases colon cancer mortality. The performance of that and how well that's done is related to the adenoma detection and resection. So adenomas turn into colon cancers for the most part. If we look for colon adenomas, we take them out, people tend to get less colon cancers. There are several technical challenges to 100% adenoma detection, right? The polyp morphology can be weird, and there can be operator error. You could sneeze, cough, not see something, pull the scope back too quickly, that sort of thing, not look behind every fold, and you can miss polyps. And also colon preparation can be a big problem, too, if the patient's particularly in the hospital, but that's a talk for a different day. So adenoma detection rate runs somewhere between 25 to up to 50% in a lot of studies. This is always hard because what's the gold standard? How do you know what you're missing? We do know that if people do sequential colonoscopies, where two experienced colonoscopists do one after the other, that the miss rate can be as high as 20 to 25%, and that there's an incidence in post-colonoscopy colon cancer is about 2%. So it happens. There's a miss rate that is involved with colonoscopy, and it happens. And the GI literature there's thousands of papers about why does this happen, how do you improve it, how do you improve upon it. But those are sort of the facts. And even despite this miss rate, colonoscopy decreases colon cancer mortality for the most part. So there's been a whole bunch of things where people have looked at it. There's been different colonoscopy devices where you can look backwards, you can look sideways, you can light things up. We tried it didn't look like this, but we played with a device here where it was a sheath on the end of a scope that looked kind of like a Christmas tree that pulled folds apart to look and see whether there was it. And there's a ton of different things where people use it. And right now, nothing has really bubbled to the top. People have filled the colon with water, and you can looked at underwater Jacques Cousteau colonoscopy sort of things, and to be honest with you, nothing is really. Am I wrong? Nothing has really come out where this is how you should do it. There are very strong devotees of every single one of these things. So and this is what I said. An endoscopy nurse actually is probably the best thing, and so or one of the and they're already there. That's not a new device, and so this is something that I think is important for at least gastroenterologists to know, that if the nurse says something, and we did have a tech here who was very good at picking up small polyps, but they also help. So this was a setup. Dr. Beard and Dr. Colloon are collaborating with a company in Israel that's trying to make a setup where you would have this is the scope processor, this is the scope. I don't think there are buttons on this scope, so I don't know what exactly she's doing. And I don't know why she's got an image of a colon when the scope is hanging, but that's a whole different thing. But where the image would be processed through a box, and the box would basically help you decide. It would analyze your image in real time, and it would help you decide whether or not you had a polyp. I don't know why there's a polyp in the cart, but that's a whole. I just looked at that. That's weird. But basically, what it does is, and this is what they're hoping to do, is they're hoping to. This is a colonoscopy image. This is a polyp, and then the machine is able to look at and tell the difference in the polyp versus surrounding tissue. It sort of generates a heat map where it says this might be a polyp. Now there's also another heat map down here that says there might be a polyp down here, and it tries to tell you that, hey, there might be a polyp here, so you can biopsy it and sample it. To my knowledge, are they doing this live now? They're not doing the live version yet, right? They're still working on the next phase. So what it does basically, it works in two ways. It sort of bounds. It sort of puts a boundary around where they're looking at, and then it then they highlighted it, and this is what they did in their training set. They basically had a number of polyps. They sort of bounded the area of interest, and then they highlighted the area of interest, and the machine was able to learn it. And what they did was basically, and Dr. Beard's basically doing the validation. You're doing a testing set now or a validation set?
A large validation set. They did a small one with the 35 videos.
Yeah, so they did 35 videos where they did colonoscopy, and they basically looked at, they put video segments that have, they tagged them looking for polyps, and then they had 100 frame segments, and they basically took out the ones that had polyps and kept the ones that did not have polyps, and they separated them out, and then they trained the computer on, they trained the algorithm using those images. And basically what they looked at about 35,000 frames with a bunch of, they found there were polyps throughout the colon, mainly in the left colon, 33 sessile polyps, 2 pedunculated, and then generally they were smaller polyps. And basically they looked at what the positivity and negativity, the true positive and false positive rates, and then whether detected polyp, and basically measured all of this. And then they compared it to whether it was in the endoscopy. And this was what they found in this set, was a 89% true positive rate with a very small false positive rate, and fairly good sensitivity and specificity. But still, not, I wouldn't say overwhelming, but not terrible for the first go of it. 4 polyps were missed by the physicians, and those polyps, and 5 were missed by the system. It turns out that the ones missed by the system were not, only 1 polyp was missed by both. So the combination of human and computer had a higher ADR than either one working together. And this data is actually similar to what you reported, right, at ACG? You did, how many patients did you report on? This was the data? Okay, yeah. And we've done 280 colonoscopies now, and we don't have any preliminary data on that yet, back, do we? So we're using what we're looking at now is we're doing screening colonoscopies. We're filming them. We're sending the data. We're sending the film to Israel, and we're basically going to get back a sort of a validation set to see how well their algorithm works. Versus, I guess, they're being reviewed by experts, and also what we report. So what we report, what the computer reports, and then the gold standard is what the experts who review every frame see on the study. So this is just what it would look like real time. This is a colonoscopy. You can see it's flagged this area that was actually fairly subtle. This is what the raw data looks like. I don't know whether they're going to report out a heat map or not, but they will not. Yeah, I wouldn't think that they would. I think this would be just confusing. But you can see here's a polyp here. And so I think this has a potential. The problem for the company is there are, about 7 or 8 companies now that are looking at this, and so it's really a race to see who can do the best job and who can have the best algorithm. But I think this is sort of the way of the future, where you get a backstop on your decision making, where you're still the arbiter, but there's a backstop on your decision making. Here's another one that we showed you in live. So that's our. So where is AI going? Probably where there's a bunch of stuff in GI, H. pylori, looking at trying to predict celiac disease, trying to decide whether an ulcer has gastric cancer, trying to help you make decisions in Barrett's, and I think looking at EUS images. I also know I gave this talk in Tulane in May. The president of the Motility Society was there, and we basically had an idea to look at esophageal motility tracings and see if there are any patterns, and use AI to look at that. So I think that'll be helpful. I think looking at electronic health records to review them at night and to look for diagnosis and suggest a diagnosis, obviously to do coding. So while Dr. Murphy's doing the procedure, actually having real-time coding come up, or the paperwork being done where the report is generated for you, so all you have to do is review it and sign it. I think that's something can be done. And then I think the last thing that's really exciting is some of these big databases that are coming online. So there are two of them. There's that I've been involved with. One is Apprentice, which is a pancreatitis consortium where they're looking at trying to worldwide look at patients with acute pancreatitis and collect all the data that they can about their treatment and the patients and that sort of thing. And I think using AI to look at this and look for patterns, I think, would be helpful. And then the other thing that's very interesting is this NIH All of Us program. Does anybody know what that is? So what the NIH is doing is it's trying to get 1 million people in a database where they do their complete genome, and they look at their genome plus correspond with their EHR and their clinical outcomes, so that as a researcher you can look at these things. If you have a question, you can look and say, what is this gene? Is this SNP? Is this something associated with this outcome? Is this, and all of this? And I think that this has the potential to be just an amazing resource where we can look and try and look for causes of disease. And of course you need big computing power for big data, and that's where artificial intelligence comes in. So a quick overview, somewhat confusing even to me, even having given the talk a couple of times, but I'm happy to take any questions that you might have or any comments on that. Gershon.